Dr. Choll Kim here from sunny San Diego, California. We are getting started. The world's greatest radiology tech right there, Big T. He and I are like dance partners, and we can do the no-look pass, and we know we'll be there for each other because we have to do a very good job on this 44-year-old visual effects artist from Hollywood. Talking about pressure, because check this out, he's got a disc herniation right there. Very annoying. It probably goes all the way across. He's got back pain and leg pain. And he has failed non-operative treatments, so we've decided to do surgery. And of course, we're going to do the most minimally invasive surgery possible. LESS, L-E-S-S, lumbar endoscopic spine surgery, which you have to admit is a very cool name for a minimally invasive procedure. We're able to make a little poke hole instead of an incision. We'll preserve that tendon attachment to this massive, powerful muscle called the multifidus. Nudge that over. It's probably stuck to that due to chronic inflammation. We'll pluck out all the disc material that's pushing on the nerve. We'll remove any loose disc material. And then we'll make sure all the nerves are completely free and clear and mobile, because they need to slide and pulsate within the canal. Whatever, man. All your negativity is just making me stronger. Shot and save here.
Got it, Doc.
Shot and save. Shot and save. Shot and save. Oh, good.
Extra large spike right in gut shock.
Shot and save.
Small spike in gut shock.
Shot and save.
Right side.
Okay, I see the leak, but there's,
Right,
oh, I see it. It's like going south. So cute. Shot and save.
medium spike lateral.
Let me have the pencil. Okay, there's the surgical target site. That's the edge of the bone. So this is the upper lateral corner of my dissection plane right here. Up there is the midline, and down here is your right side. And that's the entry point to the canal. Underneath will be a yellow ligament. Okay, that's the ligamentum flavum. It kind of looks yellow. It's kind of white though because of the light. You can see how the olden Latin people that stole graves to do cadaver work would call this yellow ligament.
How's Dr. Sir doing?
Everything is stuck to it. Look at that. Step one of the surgery, the neurolysis, the release of all the adhesions. Look at that mountain. Comes straight up. Woo, look at that. Granulation tissue right there. Blood vessels, not supposed to be there. Adhesions, not supposed to be there. Looking good now. I think I should be able to rotate this cannula now. Sweep away the dural tube. Look at that thing. And there's the empty tent sign. There's the edge of the dural tube right there. That'll be easier to sweep away one side. This is the other San Diego pimple popping maneuver. Look, you can see how it wants to just squirt out. It just needs to be freed and released. Laser next. This is like a rubbery knuckle of a disc herniation. Makes sense that it's not always hurting. Probably depends on how much pressure there is on this thing and how much hydration there is. And come flying out. Can I have a regular too, Terry? Oh yes, and there's the piece right there. Lazor. Oh, much of endoscopic surgery is about cannula manipulation and persuasion and sneaking around. You can't make any major big movements because then you'll lose your visual field. Because it doesn't matter, you still need to know where you are. Three-dimensional space, no matter how you do the surgery. Even if you have to rely on the force loop, the force, I rely on everything available to me. This is a completely sequestered disc protrusion. It does not communicate with the nucleus at all. Because notice, there's very little blue here, but this is all pathologic. There's a little bit of blue, but not due to a direct communication. So this has been there for a while, and it's separate from the nucleus, but it's still susceptible to being pressurized, and of course, doesn't have to be connected to the nucleus to cause pain. Just has to cause inflammation and pinch the nerve mechanically. Okay, I excavated all the loose stuff underneath. Okay, there's a couple of little loose pieces that I got to grab. Laser back, regular pituitary. I'm inside the disc practically. Way in the back. Can you come in with fluoro for a quick AP shot? Regular pituitary. Tilt toward the head too.
Okay.
That's why I'm not seeing the blue. It's more toward me. Okay, save that.
Okay.
Come on out.
You got it?
I'm definitely medial enough. Feeling really good. I got the disc herniation all the way to the midline. I know that's the midline just because I know. And then I also checked on x-ray. Because I'm a cheater. Backing out now, that's the dural tube right there. Kind of scary, isn't it? I bet you it's going to start pulsating in a second. That's the nerve root. But you can tell it's like floating around. And then I'm going to look way toward me. Yep, that feels solid. I like you long time. Look at that blood vessel right there to the left. Punk. Messing with me, taunting me. Surgery's all done. One very, very expensive Band-Aid. It went beautifully. We're all praying for a great result and a speedy recovery, so best wishes.